In this lesson, we're going to talk about our final type of distributive shock, and probably the most common type that most people will run into is septic shock. My name is Eddie Watson. I will be presenting this series of lessons. And again, like with all the other ones, we're going to talk about the word septic and what that means. And really, this comes from the word meaning rotten. And going way back into our past, that this is how people used to describe this, as the body was rotting from the inside out. And this is all as a result of some sort of infection. And more importantly, in the case of septic shock, this is going to come from a systemic infection, or essentially an infection or an infectious agent that is inside of our bloodstream. And so our patient can find themselves in septic shock as a result of that systemic infection, or what we refer to as sepsis. And it's really important that we really have an understanding of what's going on with septic shock, as well as how we would treat our patient with it, because septic shock comes with a very high mortality rate. Depending on where you look, the mortality rates for septic shock can be as high as 50%. So in order to really drive this point home, it's important to know the statistic that 1 in every 3 patients that die in the hospital have sepsis. And so a person with sepsis that just continues to progress, either not being treated or unresponsive to treatment, ultimately leads to septic shock. And this is as a result of the systemic infection leading to a massive release of cytokines. And so just like we did with anaphylactic shock, let's go ahead and take a look inside one of our blood vessels and take a look and see what exactly is going on with septic shock. And so, like we talked about, we have some sort of systemic infectious material, and this can be what is most commonly our bacteria, but this can also be things like viruses, fungus, or even parasites. And for this bacteria, this can be either gram-positive or gram-negative. But like I said, in most cases of sepsis, this is as a result of some sort of bacterial infection. Alright, so let's go ahead and say we have our bacteria here. And so now the bacteria has made its way into our bloodstream, and the first thing that's going to happen is it's going to encounter one of our white blood cells. And as we know, our white blood cell's job is to clean up throughout the body. And so when they first encounter some sort of infectious material, they're going to release cytokines in order to recruit other white blood cells to the area. Now, one important thing to know here is typically we have infections that are taking place outside of the vasculature. And usually these infections are localized to certain locations. But again, with sepsis and this infectious material in the blood, that this is happening all throughout the entire body. And so it's important to remember that, because what happens next is all a part of a cascade of events that are really meant to help get white blood cells to a localized infection in order to be able to fight it off appropriately. But since this is happening systemically within the blood vessels, this response ends up actually hurting us. And so what's going to happen is these white blood cells are going to release some pro-inflammatory mediators, as well as they're also going to be releasing nitric oxide. And so now, as a result of these being released, the first thing that we're going to see is a dilation of these blood vessels. So just like in our anaphylaxis reaction, we're going to see these blood vessels get larger, again leading to a drop in our systemic vascular resistance, ultimately meaning a drop in our blood pressure. Because again, think about that this is happening systemically everywhere throughout the body, causing this substantial drop in our SVR, and ultimately that substantial drop in our blood pressure. Now, in addition to that, again, we're going to have the space in between the cells of our endothelial lining are going to open up. And again, typically, this process is to open up to allow those white blood cells to get into that localized infection. But again, now this is happening everywhere throughout our body. And so really a couple things happen as a result of that. So here we have some sort of cells and some sort of tissue that this blood vessel is perfusing. And so what's going to happen now is fluid from within the intravascular space is going to start leaking out into that third space. And so as that fluid leaves the intravascular space, combined with our decrease in our SVR, this is further going to work to decrease our blood pressure. And this is as a result of something that we call a relative hypovolemia. And so if you think about that, we have a larger volume of space to be filled due to that vasodilation, as well as a decreased amount of fluid within the vasculature, leading to that hypovolemic type of state. And so ultimately, this means we're going to have less perfusion happening, which means less red blood cells coming through. And as we know, those red blood cells are responsible for carrying oxygen. And so we're going to be delivering less oxygen to our tissues. Now, in addition to that, we've now had all of this fluid that has leaked out into the third space and has surrounded these cells that normally don't have all this fluid here. And this oxygen is going to have a really hard time trying to get over to these cells, further adding to our shock state. And again, I can't stress this enough. Just remember that this is happening everywhere throughout the entire body. And so now another thing that's also going on is the white blood cell is going to be releasing certain molecules and lytic enzymes with the intention of destroying this infectious material. And again, normally this is taking place localized here in the tissues. And so here we are again in a situation where this is happening systemically inside of the blood vessels. And so this is going on everywhere throughout our body. And these molecules and enzymes, that they can actually lead to damage to our blood vessels and our endothelial cells. So now, in addition to that increased permeability from the nitric oxide and the inflammatory mediators, we're going to start to have damage and death of cells within our vasculature, which is again going to lead to more fluid leaking out, as well as if this becomes large enough, we're also going to begin to see our blood coming out here as well. And so typically what's happening in our body at this point is these damaged cells are going to release what we call platelet aggregation factor. And so what's going to happen is we have coagulation factors within our blood naturally. And this is going to lead to a cascade in which we're going to start to get a buildup of platelets in order to try and stop the bleeding that's going on or the damage. And these clots can break off and continue traveling, and if large enough and in small enough vessels, can ultimately lead to decreased blood flow or absent blood flow to certain vessels, ultimately impacting whatever those organs or tissues are. But again, most notably, we're having this buildup of clots systemically throughout the entire body, and the body only has so much of these clotting factors available. And so while we're forming new clots, we're continuing to have more damage and open up more areas. And so ultimately we find ourselves in a state where the body can no longer keep up with the amount of damage and has used up all of these coagulation factors. And so we find ourselves in this state where we continue to have bleeding, but we also continue to have this massive clotting throughout the body. And this is what we refer to as disseminated intravascular coagulopathy, or DIC for short. Now, in addition to all of this that's going on, we also need to talk about what's going on inside of our lungs. And so as we know, we've got our blood vessels coming out here into the lungs. And so all of this process that we talked about happening throughout the body is also happening all throughout our lungs. And these enzymes and cytokines are going to continue to cause damage to the vessels in our lungs, as well as the inflammatory mediators and the nitric oxide, leading to that increased capillary permeability, which is going to cause fluid to shift out into the alveoli. And so now we find ourselves in a state with damaged vessels, and alveoli, which we normally are using for our gas exchange, is now filled with fluid. And this ultimately can cause our patient to have respiratory distress, lead to respiratory failure, or ultimately lead to what we call acute respiratory distress syndrome, or ARDS, which is a very serious complication as a result of septic shock. And really the last thing that I want to talk about with this process is if we take our heart here, and again, we know we have blood that's coming to our heart, all of this stuff is going to be happening within the vessels within our heart. And so initially the heart is going to be working to compensate for that decreased SVR. And so initially we're going to see an increase in a heart rate and an increase in our cardiac output. But as that hypoperfusion and damage to the cells continues to take place, eventually we're going to see death of cardiac cells, which is ultimately going to have an impact on our heart's ability to function. And we could see a decreasing in our heart rate. And probably more common would be a decrease in our heart's ability to pump, leading to a decreased cardiac output. And so, as you can see here, this is a very complicated, cascading series of events with multiple things that are going on that are all contributing or having a part in leading to our patient being in that shock state. And so with that said, let's go ahead and move on and talk about some of the signs or symptoms that your patient might be exhibiting when they're in septic shock. And so with some of these signs and symptoms, we are going to discuss some variation that we may see between both the early versus the late stage. And this sometimes you'll hear referred to as the warm or the cold stage. And really we can just think about this as our compensated versus our uncompensated. So the first of these that we're going to see and that we're going to talk about is an increase in our temperature or fever. Now this oftentimes can be a pretty good indicator of what type of shock your patient is in. But in addition to this, when your patient is in that early stage of shock, they're also going to have warm skin. And this is essentially where the term warm stage of shock comes from. But ultimately, as the shock state progresses and continues to go on, we are going to have that systemic response and vasoconstriction, and so that will lead to our cold, clammy skin, which is what we typically would expect to see in a patient in shock. Now again, in our early stage, we're going to see an increase in our respiratory rate of our patient, but ultimately as this progresses, we're going to see our patients enter into respiratory distress, respiratory failure, or even ARDS. Often early on, you may find them to be either restless or anxious, but again, as we progress into the late stages, this can lead to our altered mental status or even being obtunded or in a coma. Now, another thing that we're also going to find in our patient is disturbances in our glucose regulation. And so I'm not going to go too deep into this here for this lesson, but this is a result of a hypermetabolic state that the patient's going to find themselves in, a lot of it having to do with this inflammatory process. And so you may find your patients with profound hypoglycemia or even hyperglycemia. In addition to this hypermetabolic state, the cells throughout the body are going to be initially using up a lot more oxygen than we normally would, also partially contributed by the fact that our perfusion is now decreased. And so initially, early on, we'll see a decrease in our venous oxygen saturation. But as things progress and we begin to really build up that fluid, we start to lose the ability for that oxygen to diffuse over to the cells. And over time, this can actually lead to an increase in our venous oxygen saturation because our cells are just unable to use the oxygen that's delivered. Now, also along with this, partially due to fever as well as the body's compensation mechanisms, we're going to see that elevated heart rate and initially that elevated cardiac output. But as things go on, like we talked about, we will see that drop down. And finally, a couple more things to look out for would be decreased urine output, as well as decreased or absent bowel sounds. And again, we talked about this within our first lesson on shock, but this is again as a result of that decreased perfusion and organ damage. So now, along with the signs that you would see, there's also going to be some diagnostic tests that you're going to want to do or perform in order to see what's going on with your patient. And really, our gold standard for septic shock is going to be our blood cultures. You're also going to want to check your serum lactate level or your lactic acid. Again, checking to see if your patient has switched into that anaerobic process or if the state of shock is progressively getting worse. You're also going to want to assess an arterial blood gas in order to assess your patient's oxygenation. You could also check a complete blood count or a CBC, and here you're really looking for either elevated or decreased white blood cells, which would be a sign of infection. And finally, you also may want to check labs for things such as C-reactive protein or cortisol level, in which an elevation of these can be indicative of septic shock as well. Alright, so we have talked about quite a bit so far, and so we're going to move on to the last part of this lesson, which is going to be talking about the treatment. And really an important thing to note to start off here is the sooner we can have treatment, the better the decrease in mortality. And so really the whole point of this is to have a prompt restoration of our normal hemodynamics. And due to this fact, there was the formation of a group of people working to really help the survival of sepsis, and they formed what they call the Surviving Sepsis Campaign. And with this, there's a lot of really great information out there for practitioners, really of all levels. But one of the most important things that we're going to be looking at, specifically within the hospital setting, is that 1 hour bundle. And these are the things that need to be done within the first hour in order to have the best possible outcomes. And these are going to be checking a lactate, getting blood cultures, and it's important that we get these blood cultures before the next step, which is our broad-spectrum antibiotics, ensuring that we fluid resuscitate our patients, and finally the use of pressors to ensure normal hemodynamics. And so we've already covered the lactate, the serum lactate level, as well as drawing the blood cultures. Like I said, the most important thing is to make sure that we get those blood cultures before we start any antibiotics. But really that first line of treatment is going to be that antibiotic treatment. And so with this, we're going to be starting like we talked about with those broad spectrum. And essentially this is to cover all areas with common, broad covering antibiotics to hopefully work to start attacking whatever organism is going on. But eventually when your blood cultures come back and you're able to do a sensitivity test and determine what organism you're dealing with, then you're going to work to really adjust that antibiotic therapy in order to specifically target. And ultimately, if your blood cultures don't come back positive or your patient is not responsive to any of this antibiotic treatment, you may also consider alternative treatments, things with antifungals, antivirals, or other sorts of treatment. And so our next line of treatment, which again, often a lot of this stuff is going on at the same time, but our next main line of treatment is going to be our IV fluids. And with this, we're really going to want to make sure that we are using our crystalloids. But for our IV fluids, we want to make sure that we are initiating this if either our patients are hypotensive or they have a serum lactate level that's greater than 4. And when we do this, we're going to be giving 30 mLs of fluid per kilogram of body mass that our patient has. Now, while we're giving this fluid to our patients, if they're either remaining hypotensive during the fluid administration, as well as staying hypotensive after we've given them this volume of fluid, then our next line of treatment is we are going to look at our vasopressors. And with this, typically Levophed is our first line of choice, and ideally we want to be shooting for a MAP greater than 65. In addition to this, we also need to support our patient's oxygenation. And this can perhaps mean our intubation or our mechanical ventilation. And in addition to this, we also need to make sure that we are supporting our failing organs. And this could really cover a whole host of different things, but this could be things like our inotropes to help with our cardiac contractility, or even dialysis or continuous renal replacement therapy in the case of failing kidneys. And note that this one is particularly common, especially with septic shock. And so finally, one of the last things that we'll talk about when we look at treatment for our patients is going to be possibly the use of steroids. And really, we're going to be looking at these to try and decrease that inflammation that's going on as a result of the immune system reaction, especially in the case where your patients are not responding to pressors. Okay, well, we covered quite a bit in this lesson, and specifically talking about septic shock. We worked to cover the basics of what septic shock is and what it means. And so really we talked through that whole pathophysiological response when your patient has sepsis or goes into septic shock, and what are some of those factors that are contributing to that. We talked about the signs and symptoms that you would look to see, making sure and differentiate between those early or warm signs versus those late or cold signs. We also talked about some of the tests that you would be looking to do for your patient. And finally went through the various treatment modalities, including covering the very important 1-hour bundle that's included within the Surviving Sepsis campaign. I know this was a lot of information, but hopefully this was presented in a way that really would be helpful for you or informative for you to be able to take this, be able to apply this information into your practice, and ultimately towards better outcomes for your patients.